Hey, class. I hope you guys are okay. It's been a little bit of time. We had spring break, all kinds of stuff going on. Um, and of course, new technologies to learn, all kinds of new ways of trying to get the information. So, um, I know it's been challenging for all of us, including me, because it's something new to me. So, without any ado, I'd like to let you guys know that we're going to actually start off with spinal cord and spinal nerves at this point. You got to remember that the spinal nerves are basically coming out of the spinal cord. They are actually going to connect the peripheral nervous system with the central nervous system without a direct connection to the brain. You might notice that when we do look at it, it's actually communicating the body's information and it's also communicating back out to the body as far as causing muscles and glands to function. When we actually look at it, you'll also notice that when we see it, we actually have the various excitatory and inhibitory type. So the excitatory and the inhibitory neurons. And you got to remember that when you look back at what you did with the muscles, because it does affect the muscles, one of the things that we see is those motor neurons will actually communicate with the muscles. And when we actually look at those muscles, one of the things that you see is when you guys remember the primary movers and the antagonistic muscles of your muscles, uh, if you had both excited, you'd have a real problem trying to get them to actually have movement. So you have to have some inhibition or reduction in responses so that the movement works correctly. And even though we don't think about it, it's one of those very important things that we actually have to adjust the muscles so that some of them are inhibited while others are being excited. So this is one of those things that's rather important. When we also look at it, you might also notice that we should also look at what can happen. For instance, a lot of times spinal injuries can actually affect the body's functionality. So one of the things that we see when we're actually examining the this whole reaction, as far as what we're looking at, as far as between the sensory and the motor at the nervous, as far as the spinal cord, a lot of times we actually look at the receptors where we actually have the sensory neuron and we have the transmission of messages with the motor neuron. But when we actually look at it, reflexes do occur. And the reflex arc is one of those things that does happen. And with the reflex arc, basically it goes from the receptors to the spinal cord and then back out to the muscle without actually having any real connection with the brain or with the neurons that may transmit messages up to the brain. Well, this may seem difficult to most people to realize, but in all reality, those interneural neurons do play a role, but it affects the response as far as information later on. But the initial response is actually when we're looking at the reflex arc that actually causes us to just respond to stimuli. For instance, if you actually were at home and you're cooking something and you pick up something that's hot, chances are you're going to actually respond by pulling your hand away from that hot object. Or if you step on a nail, and when you step on that nail, what happens is you have to have certain muscles that are going to be triggered to actually pull away while you're actually exciting other muscles to make sure you don't fall over. So this is rather important to understand. So When we're examining this, the reflex arc is one of those very important concepts to understand. And this is why reflexes are important also for diagnosing and understanding what's wrong or what's not wrong with a patient. So, a lot of times, the reflexes that we examine are very important to understand what's going on as far as the normal functioning of the nervous system. And it's our way of looking at it. So when we're actually looking at the spinal cord, keep in mind it's going to have spinal nerves. So we're going to see that they have the excitatory and the inhibitory spinal nerves, like I said earlier. And it's that summary of all those nerve impulses. We also have the tracts, and the tracts are basically essentially what may be referred to as the highways of the upward or the downward. And you might remember that the upward was basically the sensory tracts. And the downward are the motor tracts. And we actually have the spinal reflexes also. So if we were to look at a typical location in the spinal cord, what we would actually notice is that the spinal cord would actually have an appearance like this. So this is an actual picture of a spinal cord. So when we're looking at it, just like we talked about, it has the meninges, and the meninges are basically right in this area right here. They are basically that membrane, the dura mater, the arachnoid matter, and the pia mater. And basically, they also have the connection where we actually have these nerves that are coming out of it from the bone, and the spinal cord itself is where it actually comes, where we can actually communicate the information either up or down that location so that we can communicate with the brain. So when we're looking at the meninges, we talked about the meninges with the brain. So I want you to realize, basically, this is just a reiteration of the different parts of the meninges. We have the dura mater, which is the outermost layer, which is dura, meaning durable. Arachnoid matter, which is the in between where we actually have fluid, the cerebral spinal fluid, and we have the pia mater, which is very thin, and it's actually referred to as little mother. That's what mater means. And so that's important to understand. Now, when we actually look at it from an actual spinal cord, this is where we actually see it. So notice, when you're looking at this portion right here, this is the spinal cord. And you can see the nerves coming off of it. And those nerves are actually what are, the spinal cord itself is protected by the actual portions of the membranes. So why is that so important? Well, if we actually look at it, one of the things that actually is in the arachnoid matter, between the arachnoid matter and the pia mater, we actually have the cerebral spinal fluid, or what's known as the CSF, excuse me. And basically what happens is the cerebral spinal fluid was, as we talked about, actually transports the nutrients and oxygen to different parts of the brain and spinal cord. If we don't have that, we don't, because the brain and spinal cord do not actually have direct contact with the blood vessels, we don't have that capability of actually getting the nutrients. One of the things that we also may notice, and I think I may have mentioned it before we left, that if we have an infection of the meninges, then we would actually have an inflammation of them, which would actually cause a problem that's known as meningitis. So meningitis is rather important to realize as a problem that occurs. And basically, one of the things that we do to actually diagnose when this happens is basically we can do a spinal tap. So spinal taps are useful in many different ways. Spinal taps are used for introduction of antibiotics. If we actually have meningitis with a bacteria, we can actually have it where we're looking at it from the point of view of a contrast media, which basically is for diagnosis. We can actually look at it for anesthesia, such as what we see with a lot of times people have with um, epidurals, which are not just for pregnancy, but it can also be used for abdominal surgery. We also have it for chemotherapeutic medications, in other words, with drugs that are chemicals that we use for patients to actually treat them for whatever reasons that we have. And we also look at it when we actually have that spinal tap. A lot of times we actually look if there's pressure. The pressure would actually be, because most of the time it's a very gentle ooze pressure, so it's not that much. But when we actually puncture the spine at the cerebral spinal fluid with the arachnoid space, if it squirts out, we know that there's a lot of pressure, which means the person probably has meningitis. And there's different types of meningitis. There's viral meningitis, there's bacterial meningitis, and one of the big problems is if we actually have viral meningitis, usually affects adults much more readily than bacterial. But it usually causes flu-like symptoms, as does a lot of other things, including what's going on now with coronavirus. And when we actually look at the meningitis, if we have bacterial meningitis, one of the problems is if you're under the age of 12, you could be dead in 48 hours. So it's a rather important concept of understanding. And keep in mind, if you do have an inflammation of the meninges, it causes problems. It causes flu-like symptoms as just a basic thing, but it can also cause temporary blindness. It can cause problems where you may have temporary inabilities to actually move. So you might have some form of um, inability to function correctly. So it is something to be aware of. So one of the other things that we also look at is a lot of times we do this spinal tap towards the end of the spinal cord. And where do we actually see that? That's normally at about the third or second vertebrae. And that's basically where we actually have it, where it enlarges and it actually comes to the terminal end of it, which we also known as equina, cauda equina. And after that, it actually spans out. So if you're looking at this image, what do you see? You see the spinal cord, and on the spinal cord, it goes down with the nerves going out all the way down to this point, which you'll notice is lumbar 1 to 2. And basically, after that, you'll see the nerve spreading out. Now, one of the things that you'll notice, the actual spinal cord is only about 18 inches long, and it's about 3/4 of an inch diameter. But it stops growing at the age of 5. That means prior to the age of 5, you still have the ability for it to grow and increase in length. So it's something to be aware of if you're thinking about development. So when we do that spinal tap, a lot of times we take a long needle and we take it in the third lumbar to fifth lumbar, and we basically use it for samplings of cerebral spinal fluid so we can actually check the pressure, um, the if it has any growth. And keep in mind, cerebral spinal fluid, even though it has nutrients, it has the different chemicals in the cerebral spinal fluid. It does not have any organisms in it. It has no cells in it. So it is sterile normally. So that's another thing we can do. We can actually identify if there is any microbes in it. And if it does, we can actually identify that as the effect of what's causing the problem with, let's say, a meningitis or something like that. So when we look at the spinal nerves, there are 31 pairs. And I want you to look at this chart right here. So if you're looking at it, you guys might recognize that what you're seeing is it resembles something that you may notice or recognize from other times. For instance, if you actually look at it, you'll notice that it may actually look like the numerically very, very similar to the arrangement of bones, the amount of bones that are actually found in your body. So basically, you'll notice the cervical nerves, there are 8 pairs. but you have 7 cervical vertebrae, 12 vertebrae in the thoracic area, 12 nerves in the thoracic area, 5 lumbar, 5 lumbar bones. Do you see these gist? So basically, if you remember the bones and the amount of the bones, you basically can remember pretty much the number of spinal nerves. And basically, what you'll see is the spinal nerve will actually have roots. The roots are actually locations where it actually enters and it connects to the spinal cord itself, which we're going to talk about too. So when we're actually examining the spinal cord, here's a nice picture of a spinal cord so you guys get an idea of what we're looking at. So you'll notice that if you're looking at the spinal cord, which is this in cross section, you'll actually see a root coming from here and a root coming from here. These have names. One is known as the dorsal root, the other one is known as the ventral root. Basically, if you actually were to try to look at it, you might notice something very interesting about this image. The dorsal root is blue. The dorsal root has this bulge. The bulge is actually where you have the cell body of that neuron. And then the axon extends from there to the middle of the spinal cord. And the ventral root actually has this red structure. This is a motor neuron. So basically, the posterior or the dorsal root is very clear as being the sensory, and the ventral root is the motor. So if you know that, you can actually identify the orientation of the spinal cord as you're looking at it. So here's an actual picture of a spinal cord. Notice it actually has this appearance. And one of the things that you may have noticed, it has that butterfly appearance inside. So when you're looking at it, it's the butterfly is unmyelinated, which means it's made up of gray matter. On the outside is white matter. So basically, we actually see this. We also have different other structures, like in the very center, we have the central canal, which, as you remember, actually extends from the fourth ventricle of the brain, which is where the cerebral spinal fluid flows through. You may also notice that one of the things that you'll also see is that it actually has dorsal and ventral horns, which are basically these things. And you'll actually notice that there is also a great commissure that crosses the midline. So I want you to notice that, okay? So these are structures that are very interesting to know about as far as the spinal cord. Now, one of the things that we see is we actually have the anterior one, which is the white commissure, which actually connects to the white and matter on the right and left side of the spinal cord. The gray matter is divided into horns. Okay, so you have basically different horns. And the horns are those structures that look like the butterfly. Okay, and in the white matter, you divide it up. And it's in the division, it actually has what's called columns. Now, keep in mind, what did we talk about at the beginning of this presentation? We actually talked about that there are things called highways or tracks. And the tracks are where we actually have the ascending and the descending tracks, which is basically where we have our motor and our sensory nerves that are actually bringing the messages from that portion of the spinal cord up to the brain, sensory, or from that portion down to the nerves where it's actually going to go to the muscles from the brain. So when we're looking at it, you'll notice in this image, here we actually have that same image that we had before, but now you actually have things circled. Those circles are actually trying to help you understand where those tracks are located or where the columns are located. Now, it doesn't matter which part of the spinal cord we're dealing with, you're going to see it. But here's the thing. Closer to the brain you are, that's where we actually see more of the nerves coming down the rest of the body, which seems logical, but sometimes it's important to realize. But as we go down, those areas actually get smaller. So the spinal cord gets smaller because you have less nerves coming out at that point. When we look at like I said, the tracks, the sensory tracks are ascending, the motor tracks are descending. You'll actually notice that basically they do actually have specific names. And these are somewhat important to realize, but I don't think it's important enough to actually help have you remember them completely. So you have the lateral anterior spinal thalamic tracts and the posterior column tracts, which are sensory. And you have the motor tracts being direct pathways, which are lateral and anterior corticospinal and corticobulbar tracts. And your indirect pathways are basically your urospinal, tactospinal, and vestibulospinal tracts. Now, like I said, those names are not really important to remember completely, but in some ways, you have to understand them because a lot of times when you actually understand them, that will actually help you to realize why, if we have a malfunction to the body, what happened? And I want you to remember on the motor, we have the direct pathways and indirect pathways. Now, what's the difference? Direct means it comes from the brain directly out to that area, the motor, the muscle. Indirect, it's coming from other areas and actually going down indirectly, like instead of coming directly from, let's say, um, the um, upper portions of the brain, it's going to the lower portions of the brain before it actually goes down. Sort of, and here's an example. If you're actually connecting it from the cerebellum instead of the cerebrum, that would be indirect. So that's why it's important to realize. Okay. And a lot of times when we actually look at direct and indirect, we're looking at whether it affects um, what we talked about the last time, which is fine motor skills as opposed to not so fine motor skills or rough motor skills. So when we're looking at the spinal cord, though, take a look at this image. I want you to look at this because this image actually gives you nice information about coloration. The colors are there to actually reinforce the motor tracks and the sensory tracks. That's all it does. Do you need to know all those names? No, but it gives you an idea where they are. So on the left side, it's just showing the motor, and on the right side, it's just showing the sensory. But remember, in a real in the real spinal cord, it's on both paired. It's paired for both sides, so you don't have to worry about that. So in this slide, what we actually are doing is breaking it down. Now, what I want you to do is this. I want you to look at this so you have a better understanding. That's all I want you to do. So you understand why those are important. So if we look at the spinal thalamic tracts, it's used for, remember it was for sensory. So basically what we're seeing is pain, temperature, deep pressure, and crude touch. That's all it is. So what's crude touch? Basically, crude touch is you're sitting down, you feel your body touching and having pressure against the chair. So that's you're realizing you're sitting on a chair. And that's crude touch, as opposed to discriminative touch or fine motor touch, which is basically being able to touch something. Let's say you're looking in your pocket or feeling your hands in your pocket, I should say, and you feel change in your pocket. Well, just by feeling it, you can tell what coins they are. So your posterior column will actually be involved with your proprioception, discriminative touch, 2-point discrimination, which is important to actually distinguish two distinct points that are close together. And you'll notice that on your fingertips, it's much closer than you may notice on your shoulder. You also will notice pressure and vibrations. So those are all important. And when we actually get to the direct pathways, a lot of times what happens is There's a difference as whether they actually stay on that side or actually um, they actually change sides, as we talked about, if they accost in the brain at the medulla. So your direct pathways are your cortical spinal and cortical bulbar, which actually involves movements. These are motor, precision movements like um, writing, and voluntary movements. Indirect pathways, on the other hand, are the robulospinal and vestibulospinal, which are automated type things. Like it says there, posture, meaning you don't think about whether or not you're how you actually stand or sit. Your posture is learned, but you actually position body that way, which is one of the reasons that you'll notice people that do not actually have proper posture. A lot of times they learn that over time and don't even realize that. And then when they get older, sometimes that posture actually causes pain and discomfort that they didn't realize how that happened. It also involves equilibrium and coordination. For instance, you're walking. It takes a little bit of coordination to actually allow you to take your foot up off the ground and still be able to continue forward without falling over. So that's also, and it does take also other reflexes that are involved with that. So when we're actually looking at it, reflexes play a significant role with this. So when we're looking at your reflexes, like we talked about, you're not looking at the brain really getting so much involved in it, but it actually does have a predictability of how fast and how you actually may actually respond. So your reflexes can be of a spinal, cranial. It could be a somatic, which is your skeletal muscles, or it could be autonomic, which is your involuntary muscles. So no matter which one it is, it's actually to help you maintain your homeostasis. For instance, when you actually have your patellar reflex, one of the things that you'll notice, it actually responds by actually triggering a couple different types of reflex actions. So that's rather important to realize. But when we look at a reflex, you have five components. You have the receptor itself, where it is in the body, your sensory neuron, your integrating center, which in most cases, when we're dealing with the spinal cord, is going to be at that location in the spinal cord where the sensory nerve came in. Your motor neuron, where it actually may trigger muscles to actually cause it to react. And then your effector, the muscle itself. So when we're looking at that reflex arc, the simplest pattern is you just have the at least one synapse that actually is causing the homeostasis to be maintained. So as you can actually still maintain your balance. So a lot of times those, as it lists right here, the somatic reflexes will include stretch reflexes, tendon reflexes, flexor withdrawal reflex, and cross extensor reflex. So each one of these reflexes is what we see in when we actually look at the patellar reflex, just so you understand that as a concept. So when we're looking at the stretch reflex, which is the patellar reflex, basically you'll notice it actually talks about in here the different the arc and how it stretches and what happens to the brain. But visually, this is what you see. You hit the hammer on the patellar tendon, and it actually causes a movement. In addition to that, as we're doing that, what is it doing? It's also causing a tendon reflex, which is basically where you have a Golgi tendon organ, which is actually stimulated and causing pressure. So when we look at that, we see this. And where's that tendon organ? Basically, it's right up here in the tendon, right above the knee. And what we see is we also have the flexor and cross extensor reflexes, which allows you to withdraw or to actually move forward. So basically, what we see is when you're actually seeing this reflex being triggered, you also have to think that it's going to actually trigger the other leg to actually respond in some ways, a lot of times. So when we're actually seeing it, we're withdrawing. Why? Because we triggered this sense, and it's actually now something that we can actually respond to, so that we don't fall over if we were actually in a real situation. I mean, most of the time, we don't actually see people sitting down and actually tapping somebody else's knee and think it's going to be something that's really in a realistic sense. But it does represent whether or not that reflex is actually functioning the way we expect or not. So, in a clinical setting, this is rather important to actually check the patient and detect if there's an injury, as far as the nerves, as far as the muscles, and as far as the tendons. And if the response is correct, for instance, we actually have the plantar flexion reflex, which is basically where we stroke a a a a blunt object along the lateral edge of the sole of the foot. Now, under normal circumstances for an adult, you get the curling of the toes. And what do we usually use? For that, we actually use the handle of the patellar hammer. But when we're looking at an individual that's 18 months old or younger, that would be an abnormal response. But a normal response for them, because they haven't really developed the myelin, is a Babinski's response. So the Babinski's reflex would then be triggered, which would then cause the toes to flare out. So instead of if we actually looked at my hand, instead of actually having the toes curl like this under normal circumstances, it would actually flare out like this for a baby. So it's rather useful tool. So when we're looking at these different spinal nerves, we actually can name them and we can number them, and they're numbered according to where they are. But all of them are mixed. That means they have both sensory and they have motor. So when we actually look at nerves, this is interesting because if you think back about how muscles were organized with coverings and then grouped and then covered and then grouped. Well, basically, we have a very similar arrangement with the nerves. So if we look at the nerves, we have fibers, we have fascicles, we have nerves. Nerves are the biggest, which are covered by epineurium, which is made up of bundles of fascicles. Each fascicle is a bundle of fibers, which actually is covered, which is within what's a covering known as a perineurium, and each fiber is a single axon with an endoneurium. Well, here's the thing. I mentioned that the nerves themselves, the neurons, and the spinal cord do not actually have blood vessels, but nerves do within the coverings. Remember, most of the time when we actually look at coverings, they're made up of epithelial tissue and connective tissue. So the connective tissue portion, which is where we actually have the covering of the epithelial tissue, we can actually have the possibility of blood vessels. So when we're looking at this diagram gives a good illustration of how that is. And on the side over here, you actually see an electron micrograph that is actually showing the actual neurons and the fascicles. So I want you to realize that. So when we actually look at the spinal cord, here's another image of the spinal cord. Now this is a diagram, but it actually is showing also the bone. So you'll notice if we actually look at the spinal cord, here's the spinal cord, here's our roots. Notice how small they are. And then we have the bone around it, the vertebrae bone. So you might recognize this is the body and the spinous process and such. So when we're actually looking at, we have also the branches, we have the dorsal and ventral rami also coming out of it. So I want you to realize that that's something useful to understand. When we look at nerves, a lot of times they don't just come out, and sometimes they do just go out directly to that portion of the body, but a lot of times they also create plexuses. Now, what is the plexus? A plexus is basically where we have the nerve. Now, notice this image, it has the C1, C2, C3, C4, and C5 nerves. And they come out, and then what happens is they join other nerves in different ways. Now, what happens is it creates a network. That network is used in different parts of the body. So there are different types of plexuses. A lot of times these plexuses are found, as it says, the neck, the arm, the lower back, and the sacral regions. When they do that, they actually create new nerves that come out, and that's what's on this green portion where it shows the different nerves. And those different nerves will actually have an overall effect as far as that body part. Now, one of the things I didn't mention yet, but I think we will be mentioning, I don't want you to get too concerned about it, but I want you to realize that sometimes the nerve goes directly out at that same location of the nerve that it came from the spinal cord. And sometimes what happens is it goes down to a lower portion or an upper portion, and sometimes it does a looping effect. So I want you to realize that there are different things that will also occur. But sometimes these nerves play a significant role clinically. So that's why it's all important to understand some of them. So when we look at the plexuses, for instance, the cervical plexus is rather important as far as affecting the skin and muscles of the upper portion of the body, the head, neck, and the upper portion. One of the nerves that's really important is the phrenic nerve, which actually supplies the blood, the nerve responses to the diaphragm muscle. So if we actually have damage to the phrenic nerve, it will actually cause problems with breathing. Well, here's another thing that happens. When we actually look at the phrenic nerve, a lot of times what happens is we actually cause it to stop. A lot of times we use certain, like um, strychnine poisoning, to actually use as an anesthesia to stop the breathing mechanism. So if you're looking at this particular image, you'll see the phrenic nerve down over here. And the phrenic nerve is used to actually get inhibited so that we can put on a patient and intubate them so that they can actually put on a breathing machine during surgery. So that's rather important to realize. But we also have other plexuses, like we have the brachial plexus, which will affect the arm. And the brachial plexus, one of the things that actually is important to realize, it can cause a number of disorders if it's injured. For instance, waiter's tip palsy, Herb Duchenne palsy, which is where you might see somebody with their hand sort of like a waiter having their hand out for a tip. We have wrist drop, which is basically the wrist doesn't extend up. Carpal tunnel syndrome can actually be part of this. Claw hand or wing scapula, which is basically where you might notice a person's scapula being extended up further than what it normally is. So when we actually look at this plexus, here's where we actually see it. C5 through T2 is where we actually see the nerves coming out of that plexus. Now, one of the things that you'll notice is that the brachial plexus will have nerves going down the arm, and some of them will affect different parts of the arm. So I want you to realize. We have the lumbar plexus, and the lumbar plexus will actually affect the femoral nerve, which is the largest nerve arriving from this plexus. And if we actually have a problem with that, you may actually have problems extending the leg. And that's rather important to realize. We have the orbiturator nerve that could be damaged, which could have problems during childbirth. So this is which can cause sensations that you may not expect. So when we look at the lumbar plexus, this is what it looks like. Okay. But the last one, which is the sacral plexus, is probably the one most people really think about. And this is the one where we actually goes down along where it extends nerves down the buttocks and the peritoneal area and the lower extremities. And the largest nerve that comes from there is the largest nerve of the body, which is the sciatic nerve from the sacral plexus. The This nerve actually is one that could be damaged during injections on the butt. So it's rather important to realize that when we actually see it, it really can cause a great deal of injury. And there have been a lot of people that have had herniated disc and dislocated hips and other problems, and may experience pain or discomfort, including problems with a shot in the butt. So, if we're looking at it, here's what the sciatic nerve looks like. Notice how big it is. But it actually runs, if you're looking at this, it goes right across the butt. Now, we're looking at the anterior side of this butt. I want you to realize it goes right across it. So, if we're actually getting an injection right at that point and where the butt would be, you're hitting the sciatic nerve. And you don't want that happening. Um, so, if we're looking at this particular image, which now turns this leg around, this actually shows you the sciatic nerve very clearly. Let me just do this so you guys can see it. So if we're actually looking right along here, that's our sciatic nerve. So if you were to actually get an injection in that area at any time, that would then cause pain and discomfort. So that's one of the reasons we have to have the injection further up, so that there's less of a possibility of injury. Because the injury could actually cause injury that may actually cause the person to have a long term or permanent problem with the pain and discomfort, or possibly some paralysis. So it's not a good thing to happen. Now, one of the things that also happens is something called dermatomes. Dermatomes are basically related to the nerves, and dermatomes are basically also affecting areas of the spinal cord. So, you logically thinking, you have a portion of the nerves coming out, and you actually have it then affecting that area of the skin and that area of the body. So that's a logical thought, and you have it also affecting the skeletal muscles of that area, or the somatic sensory nerves. So when we're looking at it, you actually have a lot of it will actually play a role as far as referring, as far as where that sensation is coming from, or where it affects. So if we look at the dermatomes on this chart, the left side is on the anterior side of the body, the right is on the posterior side of the body. And a lot of times these dermatomes will also give us indications of referred pain. So referred pain is really important as far as looking at these dermatomes to actually where would do we expect if we're actually having a problem. If there's a patient has pain, dis- discomfort, and an inability to actually have their normal functioning. Well, where is that coming from? And maybe we can actually backtrack to where it has been affecting that part of the body as far as the organs, and possibly whether or not it's actually then something that we have to look at what nerves we have to use as far as anesthesia for that area. So you'll notice most of you have had dental work. So you'll notice that basically affects your jaw, and it affects the entire jaw. It doesn't affect just that one spot. But if you've ever had things like you hear about patients that actually have heart attacks, you typically expect that their left arm in particular, is giving indication of that pain or discomfort. So this is where the dermatomes actually play a role, is with also the referred pain. So one of the things that we see though is a lot of times with nerves, we can actually also, with the spinal nerves, we can have neuritis, which is an inflammation of the nerves, which could be related to injury, could be related to poisons, could be related to vitamin deficiencies. We can have shingles, no, not the ones on your roof, the ones you actually get from chicken pox the second time as an adult, where it affects your peripheral nerves, and it causes your basically your skin to actually have lesions that are actually hard lesions that are very painful, discomforting, and those very highly contagious. And basically, if you do come in contact with patients that have shingles, you have to be careful. You have to make sure you're not having any exposure that will actually cause you more of of contracting it and getting chickenpox again. Or you can actually look at poliomyelitis. Now, poliomyelitis is polio. You might notice that polio has affected people. It actually causes neuron death and cardiac failure and respiratory arrest. And most of us have actually been immunized by polio, either, and you might remember polio had two vaccines, which one was the Salk and one was the Sabin. Some of you might remember you might have gotten a sugar cube with a pink solution, which was the vaccine that you actually was a live vaccine that you actually had to consume. Or you may have had an injection. Those are the two types of vaccines. And polio right now is pretty much contained in most parts of the world, so it's almost been eradicated, but it hasn't been. It's still available in a couple countries. India is one of those countries, and some African, Central African nations have also been because of, well, politics as far as controlling or looks at the examination of Western medicine. So they have not allowed it. So what has happened is polio is still available in parts of the world. So you have to be cautious. So I hope that was useful and helpful. So this last slide is basically a visual representation of some of the clinical correlations to some of the skeletal nerves that we talked about. And some of them we talked about, like wing scapula and claw hand and things like that, so that you have a better visual understanding of what these clinical representations are for the spinal nerves. So I hope that's been useful and helpful. So I want you to also realize that this is new to me. It's probably new to you too. I didn't expect to ever, to be teaching a class like this online. Um, but we're in it together, and hopefully this is helpful. Now, don't forget, I did upload the actual full PowerPoint. This one is slightly abbreviated and adjusted for this presentation, so that you can actually get me presenting to you, so that you can see, that it's not just you're doing it on your own. But I want you to also realize, if you have any questions or concerns, reach out to me. I mean, you guys have my email. Reach out to me and let me know if how I did with this. And it's my first try at this, so it's not where I'm um, really experienced at this. So I want you to give me some feedback to see what I can do to help improve and to help you guys understand better. So, all right. So I guess I'll hear from you soon. Okay.